All right. Hello, everybody. Welcome. Thank you for joining us today. I hope everybody had a wonderful Thanksgiving. Um, I do see that we have some people that are already joining, so thank you. We have some more participants that are currently joining. Thank you so much for joining us today and welcome. So today we will be having a webinar on caring for HIV in the home environment, coordinating with community health workers. And this webinar is brought to you by the National Center for Health and Public Housing. So before we continue, we just have a few reminders for everybody about the housekeeping items. All participants are muted upon entry. Please make sure that you engage in the chat if you have any questions or anything that you would like to share with us. So for example, we always like to learn more about our participants, who you are. So please let us know in the chat, your name, your title, the name of the organization that you're joining us from, and what state you're also joining us from. Thank you so much. Please also raise your hand if you would like your line to be unmuted during our Q&A session. So during today's webinar, we will be having a case study which is intended to be more to provide a more engaging experience to you all. So during that session, we will be asking a few questions. So please make sure you raise your hand if you would like your line to be unmuted. This meeting is also being recorded. The slides and recording link will be sent to you all via email. I have also attached the copy of the slides into the chat, so you should have access to them right now if you would like to take some notes. And that is it for this. So about the National Center for Health and Public Housing, NCHPH's mission is to strengthen the capacity of federally funded public housing primary care, health centers, and other health center grantees by providing training and technical assistance. The content of this webinar is 100% financed by the Health Resources and Services Administration and do not necessarily represent the official views of HRSA, HHS, or the U.S. government. And I see that we have some participants right now that have provided their information. So welcome, Danelle Green. Thank you so much for joining us, Cheryl.
Oh yeah, we get a lot of Mississippi folks today.
Yeah.
Tell us where you come from.
Awesome. All right, so for today, my colleague Olajumoke Oladipo, or Jumoke, she is right here in the line. She is one of the moderators for today. She is also our health communications and research analyst at NCHPH. And myself, my name is Filipina Sandoval. I am the technical assistance manager here at NCHPH. And with us today, we also have Dr. Kevin Lombardi. He is the Director of Research, Policy, and Health Promotion here at NCHPH. And some of you may be familiar with him and already have experience with some of the webinars and other training that he has provided before. So we're very pleased to have him here, and he will be guiding all of us throughout this webinar. So now, without further ado, I will pass it on to Dr. Kevin Lombardi to get us started with today's webinar session.
Hi, everyone. Dr. Kevin Lombardi here. Just looking at our roles, we've got a lot of folks from Mississippi. I love Mississippi. I lived in Clarksdale for a while. Music and food is incredible down there. Lived in the Memphis area. Just about an hour south of the city. Really, really fabulous place. Very friendly people down there. We got someone from Unity Healthcare in DC. We're in Alexandria. I know where Unity is. That's a great center. West Virginia, Texas, Chapel Hill. Wow. Okay, great. We've got an excellent cross section of our country here, which gets me to the point. This is a forum for you guys. We're here to teach, of course, but of course also to be taught from you all, and to this really serves as a collective environment for us to discuss promising practices and to discuss our practice in health centers. So thanks for being here. Thanks for serving your community, and let's get right to it. This is caring for HIV in the home environment. Next slide, please. Here are our learning objectives. We're going to go through all of them. HIV is an incredibly challenging condition. Uh, I've seen it in a variety of different contexts, primary care, in hospital. I previously ran a health system in Haiti, and I've seen folks who have progressed to AIDS. It's not something you see in this country anymore. It's something that had been described to me by the folks that trained me that were practicing in the 80s when HIV and AIDS was a new thing. But when you see how this disease can progress and how it affects individuals, it is absolutely frightening. Folks with full-blown AIDS are well, let's just say their entire lives are shattered by this condition, and that was the reality for many years. If you got HIV, it was a sentence for AIDS. Uh, Thanks to antiretrovirals and the care that folks like you all do to get folks on ARVs and on therapy, HIV is now essentially a chronic condition. Folks can live long and healthy lives with HIV, but it requires diligence and it requires persistence and often is greatly assisted with the help of community health workers. So, what I enjoy personally about serving individuals with HIV is the impact you can have by helping them, managing their condition, managing their therapy, and living their best lives. The providing someone with a diagnosis of HIV is a very difficult thing to see. It can be shattering for many folks because their brains immediately go to that image of AIDS and that image of death and pain and shattered families. That's no longer a necessary reality. Folks can live very long, very healthy, and very full lives, but a lot of that depends on us assisting them to live the lives that they need to be healthy. So we're going to go through things CHWs can do to help folks stay on their ARV therapy, be healthy, and maintain HIV as maintain those low viral loads and keep this as what it should be, which is a chronic condition. So let's go on to the next slide and get right into it. I always like to start with some of the data to contextualize the issue. It's hard to see how important it is if you don't see the data. Data makes things real. Just want to start with a couple of studies that focus specifically on the impact of CHWs on individuals with HIV. This first study is Dranioni et al. Integrating community health workers into HIV care teams' impact on HIV care outcomes. Essentially, they looked at 10 demonstration sites. This included health centers, FQHCs, perhaps some of your own clinics, and Ryan White clinics across the USA from 2016 to 2019. They looked at 600 people with HIV who were engaged through CHW programs, and they measured various outcomes. Let's take a look. Next slide, please. What did they find? So here's some of the data, the impact on the care outcomes. So I picked three things that I thought were in particular really demonstrated the impact of CHWs on individuals diagnosed with HIV. And that was one, and these are really important metrics. Primary care visit in the past 6 months. Primary care is I can't find a word that describes how important it is for anyone, but in HIV in particular. For folks with HIV, their antiretroviral therapy is managed often by their ID doc, but their primary care physician is an important a gatekeeper for other conditions that can be exacerbated by HIV. kidney condition, chronic care conditions, cardiovascular conditions. Primary care is an important metric to really how well folks are managing their health as well. If we look at the baseline here, and it's 6 months. That's individuals with HIV who are seeing a CHW regularly. And at the beginning was before they were seeing the CHW. And the 6 months is after 6 months of working with a CHW in a coaching style dynamic where they're meeting regularly with a CHW, going through medication reconciliation, appointment reminders, and so forth. And what's the difference? So with primary care visits, we found that at the baseline, 50% had seen their primary care physician in the past 6 months. At 6 months after seeing a CHW regularly, that increased to 84%. That's a massive increase, huge. Antiretroviral therapy prescription, of course, the cornerstone of HIV treatment. The antiretroviral therapies is what keeps the viral load low. ARVs have a variety of different medications that affect the virus at different iterations in the infectious process, getting into the cell, integrating into the DNA, and so forth. These medications will keep those loads low. That's what keeps the immune system functioning, keeps those helper T cell levels at good levels, and prevents the progression to full-blown AIDS. We saw a baseline of 66.9%, an increase to 91.3%. That saves lives. And viral suppression. The 200 copies per milliliter is an important metric that shows essentially how well the virus is suppressed. And what we found at baseline was 22.4%, and after 6 months is 43.7%. This is the impact of CHWs on HIV. It is significant, it is real, and it is important to both the patient and to the health center as well. Now we understand, of course, how this affects the patient. But in a world where value-based care is increasingly a part of our lives, and that is through insurance, through accountable care organizations, and so forth, your health center, your organization is increasingly held accountable for the overall cost of care and receives financial benefits when that cost of care is reduced through various ways. It's different depending on what your payer mix is, but it is real and there every time. When folks are on ARV therapy, when they are seeing their primary care physicians regularly, their cost of care goes down, and the benefits are there for both the patient and the health center. So it's not only an important part of the health of the patient, but the health of the center as well. Next slide, please. Here's just some graphs to show the difference. They are significant, they are real, and that's the effect of a CHW in a patient's life when they have an HIV diagnosis. Now, it's not magical. CHWs do very specific things that help folks to manage their conditions, and we're going to get into those in a little bit. But to give a bit of a spoiler, this is a difficult condition to manage. First of all, rarely do folks expect when they're getting this condition. Occasionally, folks will expect that they are getting it because they've been regular IV drug users or were directly exposed. But typically, this is a total surprise and it totally changes their lives. They now have to comply with medications. They now need to comply with doctor's visits, and they need to look at their health in a very detailed way for often the first time in their lives. It's an overwhelming amount of information, and I like to think of a CHW as both an individual that helps to guide folks and through interpretation and health education to help them to digest that information. It's really common to see these folks come into the ER or come into the health center with panic disorders, anxiety attacks, new onset diagnosis of depression. And a lot of that has to do with just the overwhelming amount of information and the adaptation that they need to go through. CHWs allow them to digest that and to understand that information in a way that makes sense to them. CHWs understand their communities and understand how to speak to folks in a way that folks like I just don't. You are masters of communications in your local idioma. Next slide, please. So let's talk. Again, antiretroviral administration is a critical cornerstone component of treating this condition. That requires one, you're seeing an ID doc. That requires understanding when your appointment is, going to the appointment, getting an appointment. Often for those of you who are in rural areas, that means you need to go somewhere, sometimes an hour or more, to see an ID doc or to arrange a telehealth visit. These are logistically challenging things to do and things that CHWs aid in facilitating. Uh, there's also the organization of the medication, making sure folks have their pill boxes, have things timed appropriately, and are not missing doses. And also keeping a diligent eye on mental and behavioral health to make sure folks are seeing professionals when they need to and are engaged and happy in their lives. When people are engaged and happy, the risk of diagnosis for a mental health or behavioral health condition go down and their motivation increases, and it's much easier to stay compliant with your medication when you are motivated. And that's not just for folks with HIV, that's for every medical condition and every person. There are some barriers to integration. CHWs don't just magically show up on the scene. They need to be hired, they need to be trained, they need to be integrated into teams. Some of the issues that have been identified both by health centers and by the publication. By the way, all the links are on the bottom left. You'll be able to get that. They go right to the papers, circulate them to your colleagues, check the data. Don't take my word for it. Check it yourself. But one, unclear CHW roles and responsibilities with teams. Are the CHWs specifically assigned to be checking up on this condition? Is that explicit? Are notes being provided to on the medical record that doctors, nurses, nurse practitioners can see? These are important communication methodologies that when not present and when there aren't systems describing that, it can be difficult to see the effects of CHW integration on the condition. Two, need for ongoing coaching and supervision among CHWs. HIV is a complicated condition, and in order to be able to, in a competent way, describe, interpret things for folks, you need to go through a certain amount of exposure to the material yourself. So you're doing it right now, you're here, but this is a very complex condition, and educating yourself about the condition. And as you're learning about things, thinking, how would I describe this to a patient is an important way to, is a core component to being competent in delivery of this care. And lack of information about navigating aging and HIV. We really haven't had this issue until this generation, is that well-managed HIV is now a chronic disease. And there are a number of issues that exist in older folks that don't exist in younger folks. Kidney issues, chronic disease issues. These complicate the administration of ART, raise the risk of effects of the medication, and make it difficult for folks to stay compliant. And of course, weak or fragmented referral systems. These folks need to see doctors, they need to see specialists. If that isn't available, it can be difficult to coordinate care. Next slide, please. So let's talk about setting up CHW systems to deliver HIV care and treatment. This is an incredible publication released by a center at Boston University, a guide to implementing community health worker program in the context of HIV care. This publication goes from the foundation to the rafters, everything you need in order to start a program, a CHW HIV intervention program. It includes forms, it includes trainings, it includes everything, again, from the foundation to the rafters. So for those of you who are looking to, one, start a program, or two, improve your program, circulate this amongst your colleagues and take a look. There will be something you take from it. So of course includes templates, checklists, and metrics to be used to monitor CHW program outcomes. Next slide, please. I like to think of CHWs as the sort of eyes for the clinic. When we see a patient in the exam room, it's 15 minutes. It's quick. There's only so many things we can go through, and education time is exceptionally limited. We can do something quick, a minute, sometimes even less than a minute. But there are other things often that we're balancing, chronic conditions, other medications, other issues, recent hospitalizations. It's very difficult for a physician, nurse practitioner, advanced provider to be spending the time to educate individuals on their conditions. And that's where we have the issues when folks have the knowledge gap. The community health worker links the exam room to the community. And there are a couple of key components there that are really worth mentioning. Clinics can be intimidating for folks, especially if you are an individual who's gone through the process of testing for HIV, being told that you're HIV positive. For those folks, when they walk into a clinic, they feel it in their chest. It scares them. They have traumatic experiences related to clinics, and in general, well, I can tell you from just measuring folks' blood pressure, it's typically about 20 systolic more in the clinic than it is at home, and it's because clinics intimidate folks. When you see folks in the home, you're able to see them in their more of a natural state, and that facilitates communication. Folks can have calmer conversations, and they're also more relaxed and can receive information more readily. It's a better place to learn, and CHWs, of course, have the time to go through these things with folks, go through checklists with folks, check their medications, look at the medication bottles, look at the pill organizers, and see if things are done appropriately, and give folks feedback live on TV right there in their homes. But in particular, this is the best environment to be providing patient education. And for those of you who don't have home reach with your CHWs, it's something you should consider adding if it's something your center can financially provide for, because it will lower the overall cost of care. Next slide, please. HIV interventions. We're often with CHWs. The CHWs are a limited resource, especially as funding becomes more challenging, and many places have had to cut the number of CHWs they have. Prioritizing patients for interventions is a core component of being able to serve folks appropriately. Resources are limited, and a triage perspective is necessary in order to get the care to folks who need it the most. The data and research have identified a handful of different types of folks who are, let's say, most high yield for these intervention, who tend to benefit the most for them. And I'll go over in a minute how you can identify those folks. But if you have CHWs and if you are doing a program like this or want to do a program where at your health center where you're educating folks, doing medication reconciliation and so forth, identifying the right patients is a foundational aspect of making sure the program is effective. And if you are writing grants to try to get funding for this, it's something you need to be able to articulate. The core patients that you should be focusing on are one, patients who are not virally suppressed. These are folks that are not either aren't compliant or aren't on ART therapy. You're going to see a immediate effect of a CHW with these folks if they're able to get them on ART. That's high yield and that's life-saving. Two, new onset HIV diagnosis. A new onset of diagnosis of HIV is not something we schedule. It's a surprise to folks, and it can be life-changing and often anxiety invoking and traumatic as well. These are the folks that should be talking to someone and should be receiving that coaching from a CHW on what does a new onset HIV diagnosis mean? Patients often have very low understanding of what HIV is, and when they think of HIV, they immediately go to those pictures of the 1980s folks dying of AIDS quickly after diagnosis. That's no longer the reality, and educating folks that they have a lot of resources to be able to turn this from something that was almost certainly deadly in the past, or certainly deadly in the past, to something that is a chronic disease. Uh, Being able to educate folks like that can be an empowering experience if it's done appropriately, and can be incredibly motivating to folks as well. And of course, when people are motivated, they go to their appointments more often and they take the ART therapy. Three is unstable housing or homelessness. Uh, and this is true of chronic diseases besides HIV diagnosis as well. It's really hard to manage a chronic disease, even if you have a stable life, stable home, stable job. For individuals who are experiencing homelessness or lived in unsuitable housing or are often dislocated, that dislocation or that homelessness can often be the catalyst for noncompliance with medication. It's very common to see folks who have recently experienced homelessness who are no longer compliant with their medication. Did their medication get mailed to their house? How do they get it now? If you've just been evicted from your home, you're worried about a warm place to sleep and a meal to have that evening. Your ART therapy, although it may seem like a priority to us, to that individual, it becomes less of a priority just because of the circumstances. These are the individuals that need social support and need CHW coaching or coaching from their health center to be able to provide the transition and to provide the infrastructure so that they can keep to their appointments, they can keep taking their ART therapy, and hopefully transition to a safer and more suitable living condition. So those are the folks that should be high priority. History of missing or late appointments, and the rule is two. If someone has two missing appointments in the last 2 years, they are priority, and they should be seeing a CHW. Patients with mental health disorders, for individuals in particular with depression, anxiety, individuals that have psychiatric conditions like schizophrenia, other psychiatric conditions, it is proportionately more difficult for them to manage their condition. And that support from a CHW, that coaching, allows them to stay compliant or improves their ability to stay compliant and to manage the condition. And for those of you who work with individuals with these conditions, it's very rewarding as well because you see the impact of that empowerment on their mental health, and you can see that, wow, in addition to helping to this individual stay compliant with their HIV therapy, I'm also allowing them to be more motivated, be happier, and manage their mental health conditions better. that's a huge impact on an individual, and that feels great when you do that. Those are priority patients as well. The recently incarcerated and those who have been released from incarceration, excuse me. When an individual is incarcerated and they transition to back into the community, their entire life changes like that. And being able to, one, depending on how long they have been incarcerated, adapt to how the world is now, and two, find out what doctors they be saying, where are they getting their medications, do they have social support to be able to maintain the level of motivation needed to stay compliant. These are priority patients, and these patients should be priorities for placements with CHW and also patients with SUD as well. Uh, so, next slide. Priority patients for you. But how do you identify priority patients? No one comes in with a t-shirt that says, I'm a priority patient. You need to identify them. And that's in a couple of main ways. One, your program data. Search your program rosters of past HIV programs at your institution or partner organizations to identify priority patients. Two, surveillance data. Contact your local health department. They will know the folks that have a diagnosis in your community and may have a list of priority patients ready to go for you, or the ability to identify for you who has been recently diagnosed. That's really the key metric that they can provide. You can get that information, you can get those folks assigned to a provider, and you can make sure that they receive the support they need. And your testing data. As the testing data is going out and coming in, it goes right into your medical records system. And you should have the surveillance capacity to review that clinic testing data and identify those new diagnoses and find the folks that are high priority for these interventions. Next slide. Where I really started to appreciate, I started to really appreciate the impact of CHWs in residency during hospital rotations when I didn't have any access to the patient outside of the hospital. And once the patient was gone, I didn't see them until they bounced back. Um, uh, Social work and CHWs were the individuals that made sure that my orders were implemented in the community. And without that, those medical orders just often would just disappear into the nether and not happen. Folks go back to their communities, they get lost in the system, they get jumbled throughout the world, and they end up being off their ART therapy and coming back with a viral level that's unsustainable. CHWs provide fixes in a variety of very specific ways for that and other issues as well. And the core issues I want to focus on are one, assisting people with HIV to become aware of their status. And that's not just, hey, the test results came back and you are positive for HIV. It's what does that mean? What are the implications of that test, and how does that redefine the boundaries of your life? These are things that are difficult to say to someone or articulate to someone in any circumstance, but requires a certain amount of competency. And that means competency in terms of how folks communicate in your community, socially, the specifics of language in your area, and really understanding how folks understand these concepts generally in your area. Two, linking and engaging people with HIV to medical care. This is where folks get lost a lot of the time. And I want to focus again on folks living in rural areas where there aren't just ID doctors walking around. Sometimes it's an hour or further to get to a physician that is trained to manage ART therapy, and making sure that folks have the transportation to get there, have the link to telehealth to be able to get there is a core component to making sure folks can stay compliant. Uh, Adherence is the again the keystone. Making sure people have their medications scheduled, they know where to take it, they know when to take it. It is organized. It's in a specific place in their house. They go there at a specific time at the day. There is almost a ritual to it. Have it, in the morning when you're doing when you're eating your breakfast, having your coffee. That's when you take your first dose and making it a embedded part of their life so it isn't something that can be easily forgotten. When you increase adherence, you lower viral load. When you do the opposite, viral load's going to come up. And finally, explain the benefits of other types of assistance to people with HIV. Social assistance, transportation programs, and I want to put a plug for group therapy as well, for individual or peer support as well. Health centers have had a lot of support with a lot of success with peer support because individuals who have been living with HIV and have had success in not just maintaining the a low viral load, but maintaining success in their life as in general are really helpful here. They can help provide motivation to folks, provide a picture of success so that people can picture themselves as living with HIV and having a successful, healthy, and motivated life. Really key, really core, and an important service that pays benefits and lowers the cost of care. And remember, in a world where value-based care is knocking on our door every day, lowering that cost of care is very important to both the patient and the health center. Next slide, please. Some suggested CHW tasks and activities. And again, CHWs don't just show up and magically make things better. There are processes behind this, and there are processes involved in motivating individuals, organizing their lives, and providing that coaching and mentorship that really allows people to be successful. Here are my suggestions for you based on my own experience and based on what the literature tells us. So for those, and I'm talking about the priority patients that we looked over, new diagnosis, folks with mental health conditions, SUT diagnosis. One, weekly check-ins to measure progress that includes medication compliance checks, appointment reminders, and follow-up on referrals. Two, regular education sessions. And by regular, I mean these should be at those weekly check-ins as well. Pick a topic and go through them. HIV transmission. How is HIV transmitted? How do folks get HIV? How does the virus work? Patient safety, ARV medication basics, chronic disease, HIV connections, in particular for things like kidney disease, and wellness and lifestyle. It's interesting to see over the years that, and this is in general for a chronic disease, any chronic disease diagnosis, they can be an impetus that really forces folks to transform their lives. And I like to see these things as opportunities. So when folks have an HIV diagnosis, it can be an opportunity to facilitate a life transformation to healthier lives. This is an opportunity to educate people about their health, to get them exercising, eating better, and managing their health more diligently. And that has effects that can affect not just them, but their family and community as well. And of course, in the context of value-based care, this lowers the cost of treating a patient, and there are significant benefits for both the patient, but also the health center as well. Finally, documentation. It didn't happen if it wasn't documented, was what they taught me in the beginning, and that is very true. Uh, when you see someone during your weekly check-ins, make sure a note is in the EHR that is describing that check-in. I'm going to go over a basic sample note in a moment to show you the kind of things that we'd want to see. But these are things that people look at when the primary care physician, the nurse practitioner, or the ID doctor is seeing this patient. They're going to want to see this. It's really important collateral. It allows you to focus that visit that you have, focus those 15 minutes and coordinate care appropriately. You can, before you're seeing the patient, go and look at those notes and look over the things that the CHW or the behavioral health professional has been discussing with the patient. And that gives you a foundation of how you're going to spend that time. It makes everything more efficient. And of course, for billing is a core component for the billing as well. But making sure that is not just integrated into the EHR, but in a place where folks know where to look for it as well. That often requires system-wide education, and is an important component of coordinating care. Next slide, please. So I'll go through this quickly because I want to go into our case study. But I put a sample note in here, and it's just the basics of what you should put on. It does not take a long time to write these too. And what you'll find is when you write good notes, you provide good care. It's a structure. And when you're doing this regularly and you're using a good structured approach, your care is going to have a good structured approach. It's a catalyst. Here's just a basic note for you. Um, uh, Document your contacts, document the time, document the patient. Next slide, please. Go over what you did. Did you do here in this case, mental health counseling, substance use treatment, food support? These are all the things the CHW talked about with that patient. It's a good way to both document what you're doing, but also keep track of what you're doing with each patient. If you have 30 patients on your roll and you're doing weekly check-ins with them, it's really not possible to just keep this stuff compiled in your mind. You need to look back at your past notes. So if you're seeing Mrs. Johnson and you spend some time every week, she's a new onset HIV diagnosis, and you spend some time every week educating on a topic and document that because you won't repeat yourself and you'll be able to iterate things appropriately so that you're following things well. Last time you talked about HIV transmission. This time, talk about educate them about ART and how antiretroviral treatment really works. The documentation is a foundation. It's a scaffolding for success, and of course, allows you to document your referrals as well. Next slide, please. Don't forget about the social support as well. Use your whole ecosystem to support your patients, including things like food support, transportation support, as well, what have you. And we can go to the next slide as well. Medication notes, making sure you're documenting in a detailed way the patient's feedback about how often they're taking their ART, their compliance, and so forth. Check the refills to see if people are actually getting their refills, and ensure that the pharmacy is appropriate for them. This information is important too when folks say experience homelessness. If they were getting their medication mailed to them, something needs to be fixed, and you're not going to know that unless you had that documented. Next slide, please. And next one. So this is an example for you. Yeah, you can go straight to the case study. I was trying to be exhaustive here, but this is more for folks' use after the session. Next slide. Okay, case study. Fide Jimoke, could you pop back up, please? This is my care team. I'm Dr. Lombardi. This is Fide, and this is Jimoke, and we're going to be talking about Mr. Williams. I'm going to be inviting you all to throw things into the chat and to join the conversation as we ask questions and go through this patient. I'll be presenting it and then asking questions to Fide, Jimoke, and to the group. Mr. Williams is a 53-year-old man with a past medical history of hypertension, type 2 diabetes, and hyperlipidemia. The patient has been living with HIV since 2017 and has maintained virologic suppression since 2022. Great. With the most recent HIV viral load test indicating less than 200 copies per milliliter. He presents at the clinic today for his annual physical. Great. Next slide, please. Review of the patient's medical records indicate the following details regarding his HIV history. 1. The patient was previously followed by Dr. Jones, an ID physician who manages his antiretroviral therapy. I guess I didn't need the T there. It's hard to keep up with acronyms in this field. He is noted to have last seen him in June 2024. Okay. Mr. Williams is noted to have missed his last 2 PCP appointments. And 3, past records for viral load indicate consistent results, less than 200 copies, and CD4 levels has ranged from 700 to 1300. Okay. Next slide, please. What is your initial assessment of Mr. Jones's medical records? What do you think about Mr. Jones? I'll ask Fide to please go back a slide so folks can see that. And I will the last the one with all the bullet points, please. Yes, that one. So let's start there, and I'll start with Fide and Jimoke. Do you have any thoughts? What is your reaction to this slide in particular and our situation with managing Mr. Jones and facilitating his therapy? Any red flags here? Folks, throw it in the chat. Beat Fide and Jimoke to the punch.
One of the things that I do have the red flag for me is that he hasn't been following up with his appointments, which is part of the first physical exam or assessment that they do here.
Mm-hmm.
Now, as far as the counts for the viral load, I'm not sure what the normal range is or what you're looking for, from like a clinical standpoint. So I wouldn't be able to provide feedback on that.
Mm-hmm. Mm-hmm. Yes, I agree. Jimoke, do you have anything before we jump to the crew?
Same thing as Fide, that he missed his last appointment, and he seemed to have been consistent, but since we don't know what it could be now, it could be a cause for concern. And we actually have a hand raised.
No, please. Let's go straight to the hand.
Iris, can you unmute and let us know what you think?
Iris, could you first tell us who you are and who you serve?
My name is Iris Credit, and I'm from Claiborne County Family Health Center in Port Gibson, Mississippi. Can you guys hear me?
Yes, we can.
Nice
Thank
to
you
meet
for
you,
your
Iris.
service.
Hi, nice to meet everyone. The only red flags I see with the patient, Mr. Williams, is that I'm showing from a CHW standpoint that he has barriers preventing him from making his appointments. But as far as his viral load and CD4 counts, his CD4 counts are his CD4 levels are normal and healthy. And he's virally suppressed. So he's healthy, he's just having problems getting to his appointments.
Are you nervous that they might not still be healthy? That those levels might not still be good?
Those levels still may not be good because he have missed his last two appointments, and there is no way of knowing if he's been taking his medicine.
100%.
That
You
could be a
nailed it.
potential problem.
100%. There's a lag here, right? Like we don't have
Yeah,
new levels. We don't know what's going on.
yeah,
And
because those are past records. So
100%. So you mentioned barriers. What kind of barriers do you think might be preventing someone like this from getting to his appointment? You're in Mississippi. I think your county is primarily rural. So what would folks in your county be experiencing? There might be a barrier.
transportation.
Mm, 100%. You can't get to your appointment. You can't see your doctor. It's as simple
Yeah,
as
because
that.
that would also mean transportation to the pharmacy as well.
100%. 100%. 100%. And Jamoke, you brought this up, and Iris, you brought it up as well, is it, it, folks often have good results for years before they have an issue. And we don't know why he has an issue, right? It could be a transportation issue. Maybe their truck just broke, right? And these good 100% getting off of work, right? Life doesn't just change because you have a diagnosis. You need to change for it to conform to it. And these healthy levels will give you a sense of security that is just not reality. And we could be seeing that this patient has very unhealthy levels now, and is in severe danger for a variety of health issues and just not know. The only way we would be able to pick that up is by looking at their story and seeing that, oh, we have missed appointments, we have red flags here that make us want to check. So 100% thank you. So yeah, I'm really concerned that this patient's viral load is much higher, and I'm worried that their CD4 is much lower. And I want to see what's going on. So next slide. Yeah. So we get some social collateral. This is the Well-RX questionnaire. It's a non-medical needs questionnaire. On the bottom, on that side, I'm not sure if this is mirrored, but it says link to resource. You can pull this, put this right into your medical record. It's a great resource for especially CHWs to be able to document this stuff. What are the social issues? What are the catalysts for non-adherence? And we've got this patient here. Let's see, what are the positives? And by positives, I mean the affirmative results. Okay,
Uh,
looks like they're skipping meals. They're having trouble paying for utilities. Someone said transportation. You nailed it, Iris. And they're having trouble paying for a ride or finding a ride. Next slide, please. Unemployed or without regular income and need for a better job. So these tell a story, right? An individual couldn't maintain their employment, possibly couldn't maintain their health insurance, couldn't maintain their transportation, and then their care drops off. This is an incredibly common story, and we need to catch this stuff quick or folks will get sick. So, yeah, I'm really concerned about this patient, and I'm worried that I'm limited in the exam room and I'm limited in how I can take care of them. Next slide, please. And that's when our superheroes, the CHWs, are going to come in and tell us. And okay, so what additional questions we have for Mr. Williams after reviewing his non-medical needs questionnaires? What do we want to know?
transportation.
Yeah. How's he getting places?
Mhm.
Did he lose his job?
Yeah.
In order to match this patient to, and this is bread and butter to our CHWs, not as much to physicians and public health physicians. You guys see this immediately. But in order to match a person to resources, you need to really understand their situation and you need to to look at that information. Yeah, what happened to his employment? Danelle nailed it. Did he lose his job? Is there a way you can help this individual through employment programs, through referrals, and so forth? Job in this country, job equals health insurance. Job equals transportation. You can't just jump on a train and go to the closest pharmacy. Transportation, finances, insurance. This stuff needs to be documented, figured out, and help this individual digest this. Next slide. Okay, we're going to speed up because we're getting towards the end, and I've got some good stuff I want to show you guys. So, the exam. You perform a comprehensive physical exam and a focused interview. You find out, one, he's been unemployed for 2 years. Whoa, we missed this, right? We missed this. Oftentimes, it takes a while for this information these details to affect people. Their insurance stays on for a while. They have Medicaid, or they're able to maintain transportation. It's resident of public housing. He notes poor compliance with his ARB therapy and missed appointments, and notes stress and difficulty managing his schedule. And he experienced temporary insurance lapse after his unemployment, but he's now on Medicaid. So we have an individual who lost insurance. He's now on Medicaid. A lot of the work has been done for us. So we have a route to get him back on medication. Next slide, please. So here's what we see. Anyone know what this is? And I'll say exact condition or so this is or the exact condition or category. This is early oral hairy leukoplakia. It is an AIDS-defining condition and is the result of a very low CD4 level. You can see this sort of the oral hairy leukoplakia. You can almost scrape it off. You can scrape it off with sort of a piece of with an instrument. It just comes right off. But it is a AIDS-defining illness. Next slide, please.
We have a hand raised, by the way.
Oh yes, please, please. I'm sorry if I stole your thunder there with that. Join us.
Jamaka, would you mind unmuting the line?
Oh, it's thrush. That was my one comment. That we know that colloquially as thrush.
Well, oral hairy leukoplakia and thrush are two different conditions.
Okay.
You'll see thrush in the back of the throat, and it's Canada. But you're correct in noting that these are AIDS-defining conditions.
Right.
Folks do not have, and they're both fungal, and you don't have fungus just growing on you like a garden unless your immune system is deeply, deeply suppressed. And it tells us that CD4 level is low.
Yeah.
But these are things, and I'll tell you, as a CHW, you can check these things too.
Yeah, I've clocked KS lesions on clients before in counseling sessions.
Have you ever seen this on someone?
Yes, I have seen that and thrush.
Wow. That's incredible. That's incredible. Yeah. Dante, are you a CHW?
Yeah, I'm a long-term CHW. I'm currently based in Kansas City, but I've also done CHW work in HIV in Houston and New Orleans.
Well, thank you for your service. You folks do incredible work.
Yeah.
You facilitate the care. Doesn't happen without you. Next slide, please. Here's another look at it. And next slide, please. Yeah, so this one This is herpes simplex virus, HSV1. And again, there's two herpes simplex virus in general. The HSV1 is above the waist, HSV2 below the waist. But for folks who have HSV1, which is I think like 30% of the population, it's very high. When their CD4 count is low, they will have just explosions of HSV erupt in their oral membranes. So AIDS defining. Next slide, please. And this will be our final. So we've got and I'll say a difficult situation here. What additional resources would be appropriate for Mr. Williams at this time? And I'll say, Dante, if you're still around, what do you think? You're the expert from the field. What would be your first thing you'd do for this individual?
A dental referral. I would connect them to some of the support services in Medicaid, particularly transportation. And food resources. Like a lot of Medicaid programs have home delivery for food services, and then employment resources. I'd refer him to an organization that is focused on helping, especially folks with disabilities, with employment.
100%. And I'd say the priority for me with the ones you mentioned, and in general, is the transportation. Transportation and referral. This is an individual who can bounce back, but it's also going to be a lot of time that needs to be invested in allowing them to bounce back too. And again, we can't do it alone in the exam room. The CHW is a keystone there. Next slide, please. So we're 3 minutes over. So sorry about that, guys. I have a question here. What if your state Medicaid transport is not reliable and rides are rationed? Increasingly common issue. What I would say is very hard to manage in the moment if you don't have things set up. But there is an ecosystem of resources around you in your community through nonprofits, religious organizations, churches. They've got vans. Being in contact with your local housing organization, having transportation yourself at your organization. What I'd say is for each health center, you should be aware of what the resources are that are available and what the needs are, where the gaps are, to be able to fill in things there too. Volunteer drivers and private drivers, perfect example. There are fixes to this for these things for extreme situations. Of course, we'd all love to live in a world where these resources are rights that are available. Unfortunately, we do not live in that world. As CHWs, you guys have to fill in the gaps for us. By just figuring things out, and the key to that is knowing your community. You guys are the community experts. So with that, I will say thank you for your service to our patients, to your communities, and to our country. Keep up the good work, and don't be shy, and email, let us know if we can help you, and keep up the good work.
Thank you. Thank you so much, Kevin. Thank you, Jimoke. And thank you, everybody who joined us today. We hope that you found the information very useful, and that is something that you can obviously apply within your health center or organization. So we just have a few announcements here before we take off. On December 9th, we'll have an upcoming webinar on prevention and action in primary care practice on addressing childhood chronic disease. The link for you to register for the webinar is provided in the slides. We also have some new resources that are available on our website at nchph.org. And please don't forget to complete our post-evaluation assessment. and let us know what other topics you would be interested in hearing from us, and that would be very helpful for us. Here is our contact information, and thank you so much to everybody again for participating. Have a good rest of your day.
Take
Thank
the
you,
slides,
everyone.
use the slides, use the resources, and contact us.
Bye, everyone.